about a shoulder series, things you can do to get better images the first time around. And if you have to repeat, you'll know how, based on your image, which way to go to repeat it. So you'll get a perfect repeat on your second image. That should be all it takes. Hopefully this will help to kind of clean up shoulders and get everybody on the same page. We were going to do knees tonight too, but I think we would have been here forever. These are just kind of some of the pictures. I can't print picture or images anymore on film, but these were some of the ones that I've had from previous years that I show to my students to teach students how to do these. So our normal protocol is 2 APs, right? Internal and external. The first thing I want to talk about is those 2 pictures. Any shoulder series, really, we try to do these 2 pictures. But what these are, and I feel like there's a lot of confusion here, these 2 pictures, even though we say they're AP, they're not AP, they're AP projections, they're not AP positions. Your first picture, your internal rotation, is actually an oblique of the shoulder. Even though we say it's an AP projection. So this first picture is kind of the easiest one. It's just your neutral, internal rotation, okay? And it's not internal as far as you can. Internal rotation is palm facing backwards, really. And on this one, based off of this picture, on this one, ideally, we get the full shoulder joint, we get inferior angle, and we get the full clavicle. So you want light field all the way over. You want to see this SC joint, okay? Full anatomy on this. This is an oblique picture of the shoulder, okay? Based off of what you see on this image, you can determine pretty much how much rotation you're going to need to get an open grashi, okay? Now on the grashi, what a lot of people are doing is they're externally rotating, but they're also way up here. That's going to pull your scapula up and it'll throw off your angle. So really what you should be doing, external rotation, again, not overly, but just a nice palm forward really is external rotation. And then looking at how much of the fossa you see right here, you should be able to kind of judge how much of an oblique you'll need for this. So you can kind of gauge off of here. If you're seeing this cup almost in profile, it's not going to be a very steep angle. Whereas if you're seeing this cup almost on end, they have a really rotated scapula naturally. You'll need a lot more oblique to make that parallel to your image receptor. So the goal on this picture, open joint space, okay, complete superimposition of the anterior and posterior rims of that glenoid fossa. And what a lot of people are doing on these are they're under-rotating, or they think they're under-rotated when they're really over-rotated, and they'll go even more, it looks even worse, and then they go, well, that's the best I can do. And then they'll submit it. What you're wanting to do to get this perfectly open, your scapula needs to be parallel to the image receptor. Okay, remember some scapular anatomy, the scapular spine? You can feel it on pretty much anybody. Okay, it's what we're going to use to get a perfect Y view. Feel that scapular spine. It needs to be absolutely parallel to this. Okay, that's the easiest way to explain it, the best way to do it. It takes the guesswork out of it. Okay, make that scapular spine completely parallel to your image receptor. Externally rotate, arms still in a relaxed position. It shouldn't be too elevated because based on this, we can judge how much angle we need for this. Okay? Any questions on these 2? This is an oblique of the shoulder. This is a true AP of the shoulder. Again, you still want to ideally get inferior angle, full scapula, part of the humerus. Clavicle will look a little bit funny, but you still want to include the full clavicle on those. So they are full pictures there.
I have a quick question. This is more of a protocol thing. I know that we all try to do grashis as part of our series of shoulders. Is it actually part of the protocol that we do that, like outlet views are?
It is part of the protocol.
Okay.
Mm-hmm. Yeah, I think that was updated.
Yeah, it's been a while ago. Yeah, a couple of years ago or 2 years ago or something.
Yeah,
But
so
yes, it is.
yeah, your external rotations will always be a grashi. Here is kind of an example of what happens when you, and I think this is why people do the elevation on the arm. This cup is open. There's not much of a joint space here. It's very tight, but that is in profile, but notice it's overlapped by the ribs. So I think people look at that and they go, okay, well, I don't want it overlapped by the ribs. So then they do the arm out. Perfect. Don't delete this and just send this. Send them both, okay? This is the better image. This just shows it so it's not superimposed by the ribs. Whoever had done this one submitted them both. So really good judgment call there. If you do two of them and they look like that, perfect. So submit them both. This one is another example of a Garashi. This is a very, very good Garashi. Even though there is no joint space, patient has no joint space. If the patient does not have a joint space, you still need to get this glenoid fossa in profile. I know I hear a lot of times it's still oblique. You can still see the two rims are not superimposed, and people will say, oh, they must have a closed joint space, or they must not have a very big joint space. I can't get it open. Well, if they're not superimposed, then how do you really know? So this is a really good example of a perfect position, and yeah, that patient truly has no joint space. But unless it looks like that, if there's any two rims on there, you don't have a true Garashi position, a true AP. Now, Y views. This is the big one. This is a really, really nice Y view. Everything is lined up. You see the Y. It's framed within the cavity of the humerus. Beautiful. You have space here. You have everything's lined up really nicely, rotation-wise and angle-wise. Okay. I have a lot of examples, and we'll talk about how you can look at these pictures and determine if you're over or under rotated, or if you have too much or not enough angle. But to try to get the perfect picture the first time, what we're going to do, let me use your shoulder real quick. Y view should always be done PA. I know a lot of you guys like to do AP. They're further away, you have increased OID, they're super magnified, and they're not as good a detail. Really, protocol is that we do them PA. They really should be done PA. So, what you do, there are 2 points you're going to look for. If you line up these 2 points, you should get a perfect Y every time. Superior angle, okay? It's on the it's the top of the vertebral margin, okay? Over here. You can feel the superior angle on just about every patient, okay? You want to follow the spine around until you feel your AC joint, okay? You can feel the AC joint on pretty much every patient, okay? Once you've found those 2 points, if you have to, trace the clavicle up. Okay, there's her AC joint right there. AC joint, superior angle. So if you line that up exactly perpendicular to your board, that will be a perfect Y, okay? That's the obliqueness. That's how far you should rotate. I think the book says anywhere from 45 to 60 degrees. That's 15 degrees of error that you could be getting, okay? It probably will be somewhere between 45 and 60 degrees. But we can know for sure because we find her angle and we find her AC and we line them straight up on the board. I know a lot of people use the spine. Sometimes the spine would actually put you a little bit too steep. I think people over-rotate because of that, because they're using that spine. You'll be a little more accurate if you use those 2 points, okay? Now for the angle, thank you. There are a couple different ways to measure the angle. I always do it off of this one because it's easier to see, but it's actually more correct to do it off of this. Why? True AP. That would give you your best measurement of angle. And I actually have a picture, I'll pass this around. This is one that Josie had done, where we have the measurement angle, or the angle we measured off of the internal and the measurement angled off of the Garashi, and there's almost a 20-degree difference between the two. That's a lot. So, this one will get you close. This one actually will get you really close, but this is more accurate. And it depends too, if you're a patient on their internal, if you let them elevate when they roll in, that's a different angle. So all of these, both of your APs, your internal and your Grashi, should be done with the arm in a very neutral, very relaxed position. Anytime you let them roll it up, or anytime you bring it out like this, you're throwing off that angle. So when you go to take this picture, now you're guessing, okay? So ideally, you would measure off of this. What we're measuring is from the superior angle down to kind of the base of the coracoid. You're measuring that tunnel right in there. So you're just measuring this angle right here. That measurement, if you're shooting PA, you're going to be shooting from here down to here. You want to superimpose the superior angle over top of the coracoid. That's exactly what Lucy did here. You can almost not even distinguish superior angle because it's perfectly superimposed behind the coracoid. That's the goal. You don't want it too low, you don't want it way up high, you want it perfectly superimposed. You want this to be straight up and down. I'm gonna
Put that over the ball. Put that over the
Or you guys are going like that?
Flip it around.
Straight down. Straight down.
There you go.
Oh, over the humeral. See, I always go, that's how I do it. There, I always start it from here because that's where my beam is going to be coming. So I have a straight line there, and then you just line this up until you have the top of it over here and the bottom of it here. And that'll give you, so this one's about a 20-degree angle, maybe a 25. So you're just measuring.
So just basically where the tunnel is going to start.
Yeah, and I think so. I guess what David's doing is putting it on there.
Yeah, it's the same thing, just
And measuring. But yeah, you end up.
Okay.
Yeah, you're gonna end up with the same angle. You could also do it this way. Do it on a horizontal plane and measure it that way. So same thing. We're at about 20 again. About 15 to 20. So if you just make this your horizon. So yeah, as long as you're measuring either from straight horizontal or straight vertical. But that's how much angle you're going to put on your tube, okay? Doing the PA, you should be doing a caudad angle. And if you line up your AC joint with that superior angle, you should be getting perfect Y views most of the time. I mean, ideally. Again, with these ones, a couple things. We don't want to, like I know a lot of people pull the arm around and then line them up. No, when you pull the arm around, you're pulling the scapula, you're rolling it forward. Again, you're not in a true position. So when you're lining them up, you still want the arm in a neutral position. To get this framed in the humerus, you don't want the humerus pulled forward. Okay, so none of this, and none of this either. Having them lean in towards the board. Because if they lean, you just drop this lower, you're going to need more angle. So if you have them lean in, you're going to have to increase your angle. And who knows by how much, you're guessing again. So keep them in neutral positions. Ways to judge these. To tell if you have, first of all, obliqueness. If you're over-rotated or under-rotated. If your picture comes up and it looks like this, do we need more obliqueness or less? More. We need more. Superior angle is still too medial. We want it more lateral. Here's your vertebral border right here. Here's your lateral border right here. To get those superimposed, we need to roll the patient more. If your superior angle is still medial, like where it is on an AP, it means you're not enough. I always have my students go like this. Here's your superior angle. Here's your Y. Your acromion and your coracoid. This is what they look like on an AP. If you're obliquing, you're still not there. You want them superimposed. So if it's outside of that Y, if it's way out here, you didn't go far enough, okay? If it is inside the Y, you went too far. You have too much obliqueness, okay? So that's how you can kind of judge. If you have to do a repeat, if your superior angle is still medial, go more, oblique it more. If it's inside the Y, you went too far. Bring them back a little bit, okay? Decrease your angle, flatten them out towards the board. As far as your angle up and down, your tube angle, again, we can base it off of this superior angle, okay? This picture, is this too much angle or not enough? Too much. Look at where your superior angle is. It's very, very low. Okay. What we're trying to do with our angle is project this directly over top of this. So if we have an angle, we want to make this match this. What happens if we're too flat? Where's your superior angle? It's too high. If you have too much angle, you're going to project this point too low. It's going to be under your coracoid. So this was too much angle. Okay, see how it's real low? You can see one of your U's way down here. The other one would be way up here. Here's your coracoid. There's the base of your coracoid. So a little bit too much angle on that. These ones, you guys see those? Too much or not enough? Not enough. This picture is labeled, and I tell my students they need to label all of their Y views. Okay? They should be doing that every single time. That way we know how much they use, we can correct problems, and if you have to do it again, you know what worked or what didn't. So this is labeled 15 degrees. Not enough, right? Superior angle is way too high. If you had the right angle, they would overlap. So obliqueness is good, that we have a really nice body of the scapula, but the angle was way too high. We do not see the outlet. You have to repeat on these. More angle, okay? More angle, this one's labeled 30 degrees caudad. Perfect, very nice. Superimposed, your superior angle, you see the two U's here, but they're very, very close. You have the space of the outlet right there. Really nice picture. Another way that you can tell is based off of your humeral head. If your humeral head is so high that it looks like it's touching the clavicle, you have too much angle, okay? You don't want the humeral head so high that it's obscuring your outlet. That's why we call it an outlet view. That's the space we want to visualize. So on here, where you get the right angle, some people will be closer than others. So it's not ideal to judge off of that, but you will notice that if you have too much angle, you'll have a pretty closed space there. Okay, whereas if you don't have enough angle, it'll usually look pretty open. Okay, so that's a kind of another way to judge, and David talks a lot about that. Where the humeral head is projected, that's something that the orthopods do kind of look for. So if your humerus is on top of the acromion, you want way too far.
What do you suggest on the trauma then?
Traumas are traumas. You do the best you can, but you can still use your basic points. You know, you're going to have to do it AP, but you can still use those basic points. And if you do have to do a trauma, Y view, you roll them up, you just increase your OID. How do we compensate for increase in OID? Increase your distance. Move your tube as high as you can and your table as low as you can. You'll compensate for that and you won't get the magnification. Okay? Anytime you decrease magnification, you increase your detail, which makes it a better picture. So if you have to do them AP and roll them up, increase your tube distance. Okay?
And straight rate on the tube if you're rolling it.
If they're AP, yeah, it seems like when if they're major traumas, and you roll them up in the bed, their shoulders are always kind of elevated. Sometimes a straight ray works, but again, judge, feel their AC and feel their superior angle, and yeah, if they seem like they're parallel or perpendicular to the table, you're probably good. If they seem like they're a little angled, angle up to match it. But yeah, it's a cephalad angle on your APs. And on trauma, like true traumas, it's not very much usually because they are hurting. So their tendency when you roll them up is to kind of elevate their shoulder anyway. Well, when you elevate this end up, this whole thing flattens out. So you don't really need much of an angle at all. The axillary view. Axillaries pretty much suck. I would recommend, Chelsea and I both have this book. It's the same one that David has at The Rock. It's image analysis. Okay, if you want to be a good tech, if you want to get better, get this book or come look at our book. It tells you exactly what you need to be looking for. I think people do these in a lot of different ways. The actual best way to do them is lay them down, abduct the arm, and shoot up. It's going to be, if it's true 90 degrees, it'll be about a 30 to 35 degree angle from the lateral side of the body. Okay, it's going to be angled up, and then, you know, you're trying to cram the cassette in there. I think what some people do is they use different angles because they want it to get on the film. They don't want to project it off the film, but then you have a closed joint space. So really, you kind of defeated the purpose of even doing the picture. But that's the best way to do it because you can get so much distance. I know like at Health Center, we're super limited because of the tube. You know, when you've got to lean them over the table. Well, when you do that, you have a huge OID. First of all, so we should be increasing the distance on our tube to kind of compensate. You can't really center in the middle of the joint, so you have divergent beam, which makes it look closed. You know, you kind of have to just do what you can do over there. But over here, really, if you can lay them down, yeah, it takes a little more work, but even if they're capable of leaning over the table, it's not a good picture. Lay them down, do it actually as an inferior-superior projection. That's the best way to get these. And the way to evaluate these, kind of what we're looking for is, again, like the Grashi, we want an open joint space, okay? On this one, we don't see an open joint space. This one, the way you can evaluate these, or the way you can know if you need more angle or less angle, is, again, kind of based off of the coracoid. The coracoid and the rim of the glenoid fossa should make one clean line. See how the fossa is here and then the coracoid comes here? If you have the right angle, those should actually make one big, nice, smooth C shape. Okay? And that's kind of what we're looking for, is that nice big C shape, and then this joint space to be open. Another thing on these, this should be external rotation. So when you lay them down, you want to externally rotate the arm. Even when you lean them over the table, I know we always go like this and we just have them, that's internal. They should be fully extended and externally rotated and a true 90 degrees to get that joint space open.
That's good to know.
What do you mean by 90?
From the body, 90 degrees. The less angle you have, that's the harder time you're going to have getting that joint space open. It's doable, and this book has so many good examples of if they can't get 90 degrees, how do you compensate for it? And there are a lot of different kind of ideas and thoughts, and they have tons of pictures in here. They have a picture and they basically say, what's wrong with this picture? And then they tell you, this is how you'd fix it. This is why it doesn't look good. The coracoid is too far. The coracoid's too far into the joint. You know, you have too much angle or not enough angle. Usually what we're doing on these, this was probably too much angle because the coracoid is so far out. We'd want to be a little bit closer to the body. So they probably had, you know, it was probably coming in more like a 45. You want it a little bit closer to the body. We'll line the coracoid up more in line with that joint space, and then that will appear open. Very rarely do we ever produce any axillary images that are truly open. It's kind of like the Grashi. You want the rims to line up perfectly. You want them to superimpose, and we see, you know, what we call the donut. You see two rims. You see that parallax. So those ones, it's something to kind of play around with, but be more aware of what a good image is and why your image maybe wasn't ideal, and try to figure out, you know, based on anatomy and where anatomy sits, how you could line those up a little bit better. The only other example I had of that was this one, which is about the worst exposure, but if it were a good exposure, this actually had an open joint space. So somebody nailed it and blew it at the same time because you can't even tell. On these ones too, and I know it's embarrassing, have them move their breast tissue. You know, how many of these are on little old ladies that have everything's hanging all over the place, and you're like, oh, I'm too embarrassed, I'm just going to shoot it. Have them grab that tissue and pull it out of the way. You will get a better image, okay? They're not going to remember having to pull their breast tissue out of the way. Just ask them to do it. It's kind of like on ribs, they'll look better. But I think that's kind of, there was probably a lot of other kind of tissue in the way here, but this was actually a really good, that you guys can come up and look at it. The cup is pretty much right in line, and they've got an open joint space there. Another kind of critique on these is that you want the lesser tubercle in profile on the anterior. So you want to see lesser tubercle right here. This one actually is, that's really nice. And greater tubercle should be right down here. So ideally those two should be top and bottom. That's another way. If you can kind of palpate those, try to figure out, get those in line, that'll help you get a better picture as well.
David and I were talking about how to correct those today, and he reminded me that the core kite comes in at the superior rim of the glenoid.
Mm-hmm.
So you can kind of evaluate, okay, if my superior is in my joint space, then maybe they're leaning out too far. My superiors bring them back from their leaning so much.
So what she's saying, you're on like an AP view, your coracoid is more over the superior. It's associated with the superior rim. So yeah, that's a really good account. You can see it really well on your Grashi. It's a superior structure. Yeah, that's a good one. And maybe that helps a little bit on figuring out how to correct. Wide views are the big one. If you look at that reject thing, that's where a lot of our rejects are, is on shoulders for positioning. Yep.
Chelsea, has anybody talked about what views you want? Like, say you do a shoulder view and see a humeral head fracture. Are we supposed to, is there some set protocol about at least 2 views, or get somebody to
Well, not necessarily.
manipulated for the...
Not really. I
At
mean,
least 2. If you could
yeah,
do a
I was
wide
gonna
view.
say. I mean, most of the time you can kind of, I don't know. I mean, I don't know. I usually do a neutral and then I roll them up and try to get to whatever Grashi. And most of the
Well,
time
and-
you really kind of can.
Try to get a Grashi. Or I think people forget too that you can shoot a transthoracic.
Yeah.
If you're in a neutral this way, and you need to get 90 degrees from neutral, leave it in this exact position and shoot a transthoracic. That's an exact 90 from an AP. So, and actually, if you collimate in and use a breathing technique, I just did one a couple weeks ago, and it looks so good. So that's kind of an option too, if you're trying to demonstrate a fracture in 2 planes. Throw in Y, whatever you can, I guess.